Hello, everyone. Welcome to our Zoom meeting. Today, we're going to start. Dr. Namarik will be leading the team. And when you are ready, Dr. Namarik, thank you so much. Go ahead.
Thank you so much, Dr. Nadir. Thank you, everyone, for coming today and attending our meeting. The meeting will be conducted by the Blue Team and moderated by me, the Blue Team leader, Nadir Naim. And I hope that it's going to be an informative session, and let's get started. So I'll start by sharing the agenda of the team. Just give me a second.
I can share the agenda if you'd like me to do that.
All right. Oh, wait, it's here. I got it. Thank you, Dr. Nader. Thank you.
Sure.
Right. Are you guys able to see the screen?
Yes.
Yeah, right. So this is the agenda for today. We're going to start by presenting heart failure, which will be presented by Dr. Abdullah Abbas. And then there's going to be a presentation about the post-ortho procedure DVT prophylaxis presented by Dr. Reem and Dr. Nadine. And we're going to conclude by having project updates and opening the floor for questions and discussions. So without further ado, let's get started. Dr. Abdullah, are you ready?
Yes, I am.
All right, so the floor is yours. Please go ahead.
Okay, thanks for the introduction. I'll share my screen so everyone can see the presentation. Can you see the screen now?
We do. We see your screen, your home screen.
Okay.
Now we see the presentation. Go ahead.
Today our presentation will start we're going to talk about the heart failure itself. So our objective is to be able to describe the epidemiology, etiology, and pathophysiology of heart failure and the clinical signs and symptoms of heart failure as they manifest in older adults, appropriate management strategies, and how to provide end-of-life care with consideration of individual patient prognosis. So the topics going to be covered are epidemiology, etiology and pathophysiology, clinical features, diagnoses and management, recurrent hospitalization, prognosis, and end-of-life care. Let's start with epidemiology of heart failure. The incidence and prevalence increases with age. Leading cause of hospitalization and rehospitalizations in older adults. Median age of patient hospitalized with heart failure is 75 years, and approximately 2/3 of deaths attributable to heart failure are in patient age 75 years or older. Heart failure is a major cause of chronic disability and impaired quality of life in older adults. So, let's continue on to talk about the etiology of heart failure. Heart failure in older adults is often multifactorial in origin. Hypertension is the most common antecedent cardiovascular condition in both men and women. The next most common antecedent condition is attributable to coronary artery disease. Other common causes, including valvular heart disease, like mitral regurg, mitral stenosis, and aortic insufficiency, and non-ischemic dilated cardiomyopathy. The definitions of heart failure itself can comprise in two. The first one is heart failure with reduced left ventricular ejection fraction, or LVF, with left ventricular ejection fraction less than 40%. This happens in nearly 90% of heart failure patients who are older than 65 years old or are less than 65 years of age have this form of the disease. Heart failure with preserved ejection fraction with left ejection fraction more than 40 to 50% or around that range affected 40% of men and 2/3 of women older than 65 years of age with heart failure. Symptoms and signs of heart failure in older patients. Often atypical and nonspecific. The most common are exertional shortness of breath, fatigue, orthopnea, and leg edema. Exertional symptoms may be less prominent in older adults because of a more sedentary lifestyle. Prevalence of atypical symptoms increases with age. Decreased mental acuity, confusion, lethargy, irritability, anorexia, abdominal discomfort, or altered constipation or diarrhea. The diagnosis of heart failure. The standard chest radiograph remains a useful initial test for detecting pulmonary congestion and pleural effusions. It also excludes pneumonia as a cause of shortness of breath because it visualizes like the whole mediastinum itself in some sort of way. B-type natriuretic peptide, the PNP, and its precursor N-terminal pro-BNP are valuable in establishing the diagnosis of volume overload due to heart failure, and in particular, in distinguishing shortness of breath due to heart failure from that attributable to non-cardiac causes. But specificity decreases with age. Overview of heart failure management. Goals are to decrease symptoms and improve quality of life, reduce acute exacerbations requiring hospitalization, and increases survival. Hypertension, hyperlipidemia, and diabetes should be treated in accordance with current guidelines. Smoking cessation should be strongly encouraged and supported if indicated. We're going to first talk about therapy. We're going to have, at first, non-pharmacological ones. Heart failure patients have long been counseled to restrict dietary sodium intake to less than 2 grams per day or equal. Low sodium diets have been linked to worse outcomes in several clinical trials, and little data exists in optimal sodium intake. Most patients with heart failure should also engage in regular exercise such as walking, stationary cycling, swimming, or water aerobics. Exercise duration and intensity should be adjusted to the individual patient's level of conditioning, severity of heart failure, and comorbidities. Patients should keep an ongoing record of their daily weight. Now we're going to go to the pharmacotherapy of heart failure with reduced ejection fraction. Optimal treatment usually requires 3 or more medications, and in some cases up to 7. Almost all patients take a drug or more than that additional medications for coexisting illnesses. The problems is adherence and high potential for drug interactions because there's a lot to take, and adverse events, and of course cost, because it's like up to 7 we just said. So the cost is going to be a real significant problem, especially in countries like US. Therapy must be individualized. Consider the multiple factors that influence quality of life and other desirable clinical outcomes in older adults who have multiple chronic illnesses and limited life expectancy. First, pharmacotherapy, we're going to talk about are ACE inhibitors for reduced ejection fraction. In general, start treatment at the lowest dosage and gradually titrate to the maintenance dosage as tolerated. Contraindications include known intolerance to these agents, hyperkalemia, hypotension, and severe renal insufficiency in patients not currently undergoing dialysis. Other common adverse events include cough in 5 to 10% of patients during long-term treatment, mild worsening of renal functions, often transient, hyperkalemia, hypotension, GI distress, and rarely angioedema. ARBs, or angiotensin receptor blockers, are an option for heart failure patients unable to tolerate ACE inhibitors because of cough, allergic reactions, or GI disturbances. Second drug we have for heart failure with reduced ejection fraction, we're going to talk about beta blockers. As with ACE inhibitors and ARBs, treatment should be started at the lowest available dosage and gradually titrated to the maintenance dosage over several weeks. Contraindications include severe decompensated heart failure, active bronchospastic lung disease, marked bradycardia, relative hypotension, significant atrioventricular nodal block, and known intolerance to beta blockers. Next class of drug, we have ARNIs, or angiotensin receptor blockers, plus neprilysin inhibitors. First one we're going to talk about is sacubitril. Sacubitril acts to raise the levels of several endogenous vasoactive peptides, including natriuretic peptides, bradykinin, and adrenomedulin. Valsartan plus sacubitril can be used as an alternative to ACE inhibitors or ARBs in person with heart failure with reduced ejection fraction in New York Heart Association or NIHAC class 2 to 3. Symptoms like in GRS table 3 who have previously tolerated treatment with ACE inhibitors or ARBs. Contraindications: angioedema. Adverse events: ARNIs may be associated with mild worsening of renal function, hyperkalemia, and hypotension. So as you see, like most of these drugs, you can see even in beta blockers or ACE inhibitors are related to the same kind of genre in common adverse events like hyperkalemia, hypotension, GI distress, angioedema, because you can see all those drugs trying to decrease the burden on the heart. So decreasing this burden, like an overcompensation kind of way, will lead to this adverse event. Next, we have diuretics, an essential component of heart failure therapy in most patients, because we have to decrease the volume itself. We're going to decrease the burden on the heart. Most effective agents for relieving congestion and edema. In general, the diuretic dosage should be adjusted to maintain euvolemia. Manifested by the absence of pulmonary rales and S3 gallop, increased jugular venous pressure, hepatojugular reflux, and peripheral edema. Another diuretic we have is aldosterone antagonist. The aldosterone antagonist, for example, spironolactone. Spironolactone has been shown to reduce mortality and hospitalization in patients with NIHAC class 3 to 4 heart failure and left ejection fraction less than 30% or equals. The selective aldosterone antagonist, eplerenone, has been associated with improved outcomes in patients with recent MI complicated by heart failure or left ventricular ejection fraction less than 40%. And in patients with NIHAC class 2 heart failure and left ejection fraction equals to or less than 35%. Potential harms of aldosterone antagonist. Older adults are at increased risk of acute kidney injury and hyperkalemia, including death from these conditions. Check potassium and renal functions 2, 3 days, and 7 days after initiating treatment. And it is contraindicated in patients with creatinine more than 2.5 milligrams per deciliter or serum potassium more than 5. Other therapies for heart failure with reduced ejection fraction, we have digoxin, improves symptoms and reduces heart failure hospitalization in patient with the reduced ejection fraction heart failure, but does not decrease mortality. This is like the most important thing about the digoxin. It improves symptoms, but it does not decrease mortality. So target digoxin concentration between 0.5 to 0.9 nanograms per milliliter. And adverse events include nausea, visual disturbances, and cardiac arrhythmias. And just to know that in visual disturbances, some people might complain about like a yellowish golden hue in their eyes, just like a filter. So it's a side effect of the digoxin. Some people might it's called a xanthopsia. So the combination of hydralazine nitrates is recommended for heart failure patients with contraindications to ACE inhibitors and ARBs, and in Black patients with advanced heart failure as an adjunct to ACE inhibitors and beta blocker therapy, because nitrates will decrease the preload and hydralazine will decrease the afterload, so the burden on the heart will decrease. Other therapies for the reduced ejection fraction heart failure is the current guidelines suggest, therefore, recommend against routine anticoagulation in heart failure patient in the absence of atrial fibrillation. For heart failure patient with comorbid atrial fibrillation, long-term anticoagulation with warfarin or one of the newer oral anticoagulants, just like rivaroxaban, is indicated in most cases. So now we're going to go to the pharmacotherapy in the preserved ejection fraction heart failure. Optimal therapy remains undefined. Current recommendation is aggressively treat hypertension. It's going to lead and any other risk factor associated with it. Manage comorbid coronary artery diseases. Maintain sinus rhythm or effective rate control in patient with atrial fibrillation. Judiciously use diuretics to maintain euvolemia while avoiding overdiuresis. Many of these patients are volume sensitive. Next, we're going to talk about the ICD, or implantable cardiac defibrillator. It reduces mortality, unlike digoxin, just we said, from sudden cardiac death in patient with heart failure and left ejection fractions equals to or less than 35%, regardless of ischemic or non-ischemic etiology. Prophylactic treatment is advised for patients with NIHAC class 2 or 3 heart failure, left ventricular ejection fraction equal to or less than 35%, and life expectancy a year or more with good functional status. Defer ICD implantation for more than 40 days after acute MI and 90 days or more after a new diagnosis of dilated cardiomyopathy. In the latter case, because left ventricle function often improves after initiation of beta blockers and ACE inhibitor therapy. Consideration related to ICD implantation. You have the mortality benefit of ICD therapy. It declines with age due to competing risks of death. Risk of complication from ICD implantation is greater in older adults, and we should proactively discuss disabling device near end of life. Next, we're going to talk about CRT, or cardiac resynchronization therapy. A biventricular pacemaker with one lead in the right ventricle and the second lead inserted retrograde into the coronary sinus to stimulate the left ventricle. Or it's indicated in patients with asynchronous left ventricular contraction, most commonly related to left bundle branch block, present up to 30% of patients with reduced ejection fraction heart failure. It improves symptoms, exercise tolerance, and quality of life and survival in selected patients with advanced systolic heart failure and persistent severe symptoms like class 3 or 4, despite conventional medical therapy. Recurrent hospitalization. Up to 50% of patients with heart failure are readmitted within 6 months after the initial hospitalization. Only a third are readmitted with congestive heart failure as a primary reason or readmission. Common alternative reason for readmission includes pneumonia, chronic obstructive pulmonary disease, sepsis, and other cardiovascular condition, including acute MI. Patients who experience recurrent heart failure hospitalization should be questioned carefully and educated appropriately about adherence to medication regimen, like, for example, using of OTC medication, over-the-counter drugs, and recent change in weight, recent dietary choices, and daily fluid intake. Now, after that, we're going to talk about the prognosis. The median survival rates from 2 to 3 years is 25% to 30% of patients die within first year after initial diagnosis. 50% survive to reach up to 5 years, and 20% to 25% survive past the 5 years point. Women and patients with heart failure with preserved ejection fraction have somewhat better survival rates than men and patients with heart failure with reduced ejection fraction. End of life care, we're going to talk about counseling the patients to prepare an advance directive, which may include the appointment of a surrogate decision maker and the delineation of interventions desired to be avoided in the events of clinical worsening and approaching death. Ask patients with ICDs to indicate under what condition they would want the ICD turned off to avoid repetitive painful shocks at the end of life. In patients with particularly poor prognosis and remaining life expectancy less than 6 months, offer the option of a transition to hospice as part of a candid discussion about prognosis and goals of care. We have the Choosing Wise organization. It's more like an educational campaign. It's an United States-based health educational campaign led by the ABIM, or the American Board of Internal Medicine. It's about like stopping or discussing the unnecessary healthcare. Undermining it, let's talk about the Heart Rhythm Society. It says, don't implant an ICD for the primary prevention of a sudden cardiac death in patients unlikely to survive at least 1 year due to a non-cardiac morbidity. And the American Academy of Hospice and Palliative Medicine, don't leave an ICD activated when it's inconsistent with the patient's or family goals of care. And the American Society of Nephrology says avoid non-steroidal anti-inflammatory drugs or NSAIDs in individuals with hypertension or heart failure or CKD of all causes, including diabetes. Let's summarize. Heart failure is the leading cause of hospitalization in older adults and a major source of chronic disability. Older patients with heart failure are more likely to be women and more likely to have preserved left ventricular systolic function. ACE inhibitors, ARBs, beta blockers, aldosterone antagonists, and in selected patients, hydralazine and nitrates reduce morbidity and mortality from heart failure with reduced ejection fraction. No pharmacotherapy for the preserved ejection fraction has been definitely shown to reduce mortality. Optimal management of heart failure in older patients often requires multidisciplinary approach. So we have cases just to like implement what we just said. Case number 1 says a 73-year-old woman comes to the ER because she has shortness of breath. She has had increasing difficulty with ADLS for 1 month and dizziness with minimal exertion for 10 days. She has been hospitalized 6 times within the last 6 months for dyspnea, chest pain, and lower extremity edema. History includes coronary artery diseases, peripheral arterial disease, renal artery stenosis, and diabetes. Medications are aspirin, clopidogrel, carvedilol, lisinopril, isosorbide mononitrate, and furosemide. Examination says blood pressure is 161 over 112, heart rate is 114, respiratory rate is 24, BUN is 24 milligram, creatinine increased from normal to 1.57 milligrams. Echo says dilated left ventricle, like ejection fraction, around 20%, moderate mitral regurgitation. Intravenous furosemide is administered and bi-level positive airway pressure with BiPAP is ordered for hypercarbic respiratory failure. Which of the following intervention is least likely to improve this patient's quality of life and reduce the risk for subsequent readmission? Can someone please answer this one? So, The least likely one to be the initiation of intravenous inotropic therapy. Because we said the least likely to improve the patient quality of life and reducing the risk for subsequent readmission, we just said digoxin. Second case said, a 77-year-old man was discharged 1 week ago from a nursing facility where he recovered from below the knee amputation of his left leg. At the nursing home, he gained weight and mild ankle swelling developed. The medical staff added pymetinide to his drug regimen. Since returning home, he has had increasing dyspnea with activity and orthopnea. The edema has progressed in his lower extremities with possible dehiscence at the amputation site. History says ischemic cardiomyopathy with ejection fraction around 42%, coronary artery disease, diabetes, and peripheral vascular disease. With a 4-vessel CABG 10 years ago has been done. Medication includes aspirin, hydralazine, isosorbide dinitrate, insulin glargine, insulin aspart, lisinopril, pymetinide, and carvedilol. Examination says the blood pressure was 129/70, heart rate is 77, beats per minute, respiratory rate is 18 per minute. Bilateral edema in lower extremities with BUN reaching to 27 milligram per deciliter, an estimated glomerular filtration rate around 57. Which of the following would be the least appropriate for managing this patient congestive symptoms? Is it restrict sodium intake to less than 1.5 grams a day, or restrict fluid intake to less than 2 liters a day, or double the dose of pymetinide, or add metolazone 5 milligram daily? The answer is restricting sodium intake to less than 1.5 gram a day, because we said even like 2 grams, restricting it less than even 2 grams per day is still not protective or decreasing mortality. Thanks everyone for listening. These are the slides editor and chapter authors and question authors. Appreciate your time.
Thank you, Dr. Abdullah. Thank you for this excellent presentation and comprehensive discussion about a vital topic like heart failure, especially in geriatric patients. Your clear explanation about how to diagnose, the treatment options, the non-pharmacologic therapies, the prognosis, and the cases you've provided at the end of presentation, all these were very helpful. Overall, it was a comprehensive session. So thank you for your efforts. Really appreciate it. Good job.
You're welcome.
Next, please, guys, if anyone has any question for Dr. Abdullah, please go forward. Right, I don't see any questions on the chat box. So let's move to the next topic. Next topic will be discussing the DVT prophylaxis after orthopedic surgery, and that would be presented by Dr. Reem and Dr. Nadine. Are you guys ready?
Yes, we're ready. I'm going to share my screen now.
All right, go ahead.
So is my screen clear? Can you see
Yes.
the Okay, great. Good evening, everyone. Hope everyone is doing well. Today we're going to talk about DVT and post-orthopedic surgery in geriatrics. We're going to give you
Nadine? Sorry,
Yeah?
but can you please make it bigger?
Okay, fine. I can't actually because I'm sharing from my phone.
Oh, okay. All right.
And Dr. Nadine, when you have a minute, maybe you can turn
Switch to the other. Yeah.
font. No, turn the font to the side.
Oh, okay. Let me try.
instead of upside down, just tilt it to the right. Yeah.
Thank you so much. Yeah.
Yes.
So we're gonna be
Make
presenting.
it smaller a little bit smaller, more, so we can see the whole slide. You don't know. Yeah. Smaller, more. Yeah. Now it works. Yes. Go ahead.
All right, so Dr. Reem and I will be talking about DVT prophylaxis, and we're going to give you an overview of the risks for DVT in post-orthopedic surgery in geriatrics, and we're going to be talking about the prevention of it. So we're going to talk briefly first about the definition of DVT, which is a deep vein thrombosis. So it refers to the formation of a thrombus, which is a blood clot in deep veins, typically in the lower extremities. So the common sites for it is the calf vein, femoral vein, and iliac vein. The significance of DVT or deep vein thrombosis is that it can lead to a life-threatening complication such as PE and other complications we're going to talk about more in this presentation. So I made sure at the end of each slide to add the reference points from where I got my information. So you can read more in depth for it. So after talking about the definition, I'm going to be explaining more about the pathophysiology of the disease or DVT. So the pathophysiology here, we are going to talk about first versus triad, which contains of stasis, endothelial injury, and hypercoagulability. This is one of the pathophysiologic causes of DVT. Next up, which is more common in geriatrics, which is post-surgery immobilization, which is basically not moving for a prolonged period of time, especially post-op, and tissue injury, which activate the clotting cascades. One of the main risk factors for DVTs, first of all, is the age, more than 60 years, orthopedic surgery, which is like hip or knee replacement. Comorbidities, which increase the risk for DVT, is obesity, cancer, prior history of DVT/PE, and there are other more risk factors we're going to be talking about later. And for about this topic about orthopedic procedure, the incidence for DVT in this type of procedure ranges up to 40 up to 60% in major orthopedic surgery, especially after hip fracture and surgery, hip fracture surgery and THR. Use of tourniquet and immobilization and bed rest cause venous blood stasis, which was one of the pathophysiology of the disease. Surgical manipulation of the limb causes endothelial vascular injuries. Trauma, which increases thromboplastin agent. And use of a PMMA, a bone cement, which increases the hypercoagulability. And those are like one of the components of the versus triad we've talked about earlier. All of these increase the risk of DVT, and it ranged for the percentage of it 40 to 60%, especially after orthopedic surgery. The burden of the disease, burden of DVT, and the global impact of the disease. As I've mentioned earlier, it is a leading cause of in-hospital mortality, and most importantly, it is a preventable in-hospital mortality. It accounts for 10 million cases, approximately 10 million cases of annually worldwide. The economic burden of the disease, high cost of treatment and management, as it also prolongs the hospital stay. The clinical consequence of it is chronic venous insufficiency and PE, which is a pulmonary embolism. How to suspect if the patient actually has a DVT? Well, the clinical presentation and the symptoms of the disease is very indicative of it, as if like the patient will be presenting with swelling, pain, redness, and warmth in the affected limb. Most of the cases also as well can be asymptomatic in some cases. We can go for the signs, talk about the signs. Signs, we have a positive Homan's sign, which is a pain on dorsiflexion of the foot. But this sign has a low sensitivity and low specificity. Other differential diagnoses for these kind of symptoms, it could be cellulitis, Baker's cyst, muscle strain. So how to decide if the patient is actually low risk, moderate, or high risk. And this score is gonna lead us for the next step in management or in the investigation of a patient with DVT. So the patient we're gonna talk about Wells score. So first of all, the patient gets, if he has an active cancer, he gets 1 point. Immobility for more than 3 days or major surgery in less than 4 weeks, he get a point. Calf swelling more than 3 centimeters compared with the calf gets 1 point. Collateral superficial vein present, he gets 1 point. Entire leg swollen or localized tenderness along deep vein system, bedding edema greater in symptomatic leg, paralysis, paresis, or recent immobilization, or previous documented DVT, all of these gets 1 point. If alternative diagnosis is more likely, you subtract more than 2 points. But there's also, I have to mention, there's a modified Wells score. So in the modified Wells score, if the DVT is more for PE, that's for PE. If the patient no other diagnosis is more likely, he gets 3 points. If there's signs and symptoms of DVT, he gets 3 points. If there's a history of cancer or hemoptysis, he gets 1 point each. 1.5 points if there's recent surgery or tachycardia or symptoms for PE, or heart rate more than 100 beats per minute, he gets 1.5 points. And according to that, we can calculate the risk according to how many points he have. So 0 to 2, that's a low risk for DVT. 1 to 2 is moderate risk, and more than 3, it's a high risk for DVT. This leads us for the screening and investigations for the disease. We have 2 options. First, we can go for the non-invasive tests, which is the D-dimer. It is considered to be a high sensitivity but low specificity. We can go for a compression ultrasound, which is the preferred initial test for DVT. Advanced imaging, venography, which is the gold standard but invasive, CT venography or MRI, which is used in complex cases. And then we can go for definitive investigation, diagnostic imaging, venography, detailed visualization of the thrombi, and it is rarely used due to its invasiveness. Ultrasound, high sensitivity for proximal DVT. Limitation is in detecting the small or distal clots. D-dimer test, elevated levels indicate fibrinolysis used to rule out DVT in low-risk cases. And this is according to how many points you get in according to the Wells score. From here, Dr. Reem is going to carry on with the presentation.
Hello everyone. Hello, Dr. Nadir. Hello, Dr. Nadine. Thank you everyone for this opportunity. My name is Dr. Reem Nadine. I'm going to continue the presentation. Okay, regarding the DVT in orthopedic patients, we have to first assess the patient regarding his risk factors, and this is according to the risk assessment model. We have to identify all of the patients who underwent orthopedic surgery, all the patients who are at risk for developing DVT post the surgery, and to predict precisely the level of the risk. We can divide the risks into strong risk factors and moderate risk factors and weak risk factors. Okay, for example, the strong risk factors like hip and leg fracture, hip or knee replacement, major general surgery, major trauma, or spinal cord injury. Moderate risk factors include arthroscopic knee surgery, central venous lines, chemotherapy, congestive heart failure or respiratory failure, hormone replacement therapy, malignancy, or contraceptive therapy, paralytic stroke, pregnancy or postpartum cases, previous venous thromboembolism, or thrombophilia. Weak risk factors include bed rest for more than 3 days, immobility due to sitting, increasing age, patients who are like more than 65 years of age, laparoscopic surgery, obesity, pregnancy and antepartum cases, and varicose veins. Okay, why do we need thromboprophylaxis in orthopedic surgery? The incidence of venous thromboembolism after orthopedic surgery is very high, especially nowadays. It can reach 40 to 60% in the first 7 to 14 days post-surgery. Okay, next slide. Regarding the prophylaxis, it include mechanical and pharmacological thromboprophylaxis. We usually use a combination of both. But it can be according to the cases. Some cases can have only mechanical, and some cases can have both, and some cases can have only pharmacological. Okay, regarding the mechanical prophylaxis, we have first mobilization. Okay, mobilization is like the most simple and most applicable method we use for venous thromboembolism prophylaxis. It's very easy, and any patient can afford, and it's associated with a very low incidence of post-surgical venous thromboembolism. The second mechanical prophylaxis is graduated compression stocking. As you can see in the second picture on the right side, it's like a stocking that covers the lower limb from the mid of the thigh till the foot. It needs to be sized and fitted according to the patient. The problem with these stockings that they can compress the tissue, they can compress the muscles and cause impairment in tissue oxygenation. They can even lead into compartment syndrome and ischemia. Also, the third mechanical prophylaxis is IPC, which is intermittent pneumatic compression device. There's a picture on the left side below. This device works by stimulating the endogenous fibrinolytic activity of the patient by reduction of the plasminogen activator inhibitor levels. The problem with this device that it's difficult to implement, and the compliance of the patients is usually low. Okay, regarding the pharmacological prophylaxis, we have three main treatments that are used nowadays. The first one is antiplatelets like aspirin. Aspirin is used very commonly nowadays, and it's very inexpensive, and it's used orally administered, so it's easy to be used by patients. The second drugs are unfractionated heparin and low molecular weight heparin. Okay, unfractionated and low molecular weight heparin are used nowadays as the mainstay treatment, usually for deep vein thrombosis and venous thromboembolism. They are used subcutaneously, and we usually use the low molecular weight heparin over the unfractionated heparin. The only cases we use unfractionated heparin are in patients with renal impairment. Also, the good thing about those drugs that they can be used safely in pregnancy. The third drugs are used are oral anticoagulants. These drugs like direct factor 10 inhibitors and direct thrombin inhibitors. Direct factor 10 inhibitors, for example, like rivaroxaban and apixaban, and direct thrombin inhibitors like dabigatran. These drugs are novel drugs that are recently are found, and they have like very good outcome on the patients. Okay, next slide. Regarding the guidelines for prophylaxis overall, we have like different guidelines. Like the first guidelines are guideline like American College of Chest Physicians. and the National Institute for Health and Care Excellence, which is nice, and the American Academy of Orthopedic Surgeons guidelines, the SIGN guidelines, and the British Orthopedic Associations. The current guidelines that are most commonly used are the ACCP and the NICE guidelines. So we are currently going to discuss those. The American Academy of Orthopedic Surgeons guidelines are modified actually the ACCP guidelines are modified in 2012 to be the same as the American Academy of Orthopedic Surgeons. So we are going to drop that. Okay, regarding the ACCP guidelines that are modified in 2012, it can be summarized as that any patient who underwent joint replacement should be given low molecular weight heparin or aspirin or apixaban or dabigatran or rivaroxaban, which are the oral anticoagulants, in a minimum of 10 to 14 days following the joint replacement surgery, with the low molecular weight heparin as the first choice of all these drugs. Okay, we have a slide, the next slide that can have the whole details of the clinical practice guidelines of the ACCP, but in summary, we just use the low molecular weight heparin for 10 to 14 days following the joint replacement therapy. If there is any contraindication or any a situation which we cannot use the heparin, we can use the other drugs. Okay, next slide. For the NAS guidelines, we have it can be separated for patients who have elective total hip replacement or elective total knee replacement. For patients who underwent elective total hip replacement, the patient should undergo one of the following. Either the patient should have low molecular weight heparin for 10 days followed by aspirin for 28 days. Or the patient can have low molecular weight heparin in combination with compression stockings for 28 days. Or either he can have oral anticoagulants for more than 14 days. If the patient underwent elective total arthroplasty, the patient can take either aspirin 75 or 150 milligram for 14 days, or low molecular weight heparin in combination with compression stockings for 14 days, or oral anticoagulants for more than 14 days. Okay, we discussed the overall guidelines, but we need to know what is the timing and the duration of the prophylaxis for the patients. The patients need to start their prophylaxis for 12 hours preoperatively or 12 hours postoperatively. And the thromboprophylaxis should continue for a minimum of 10 to 14 days. Okay, the ACCP guidelines says that we can have like an extended thromboprophylaxis for like 28 days, but this is not the first option. Most of the studies say that the patient does not need to have an extended thromboprophylaxis, that 10 to 14 days are enough. And thank you.
Thank you, Dr. Nadine and Dr. Reem, for this great, comprehensive, to the point presentation. Discussing the vital topic of DVT prophylaxis, very important, especially given the serious consequences can have of losing a limb or even losing a life in case it leads to pulmonary embolism or life-threatening condition. So your detailed presentation about how to recognize it, the symptoms, the risk factors, the options of treatment, and the duration of treatment, discussing different types of treatment. All these information were really valuable, and I believe it will help all of us during our practice and during our career. So thank you so much. Great job. So let's open the floor for questions. Anyone? Any question? I believe Dr. Reem and Dr. Nadine, they didn't leave us with so many questions in our mind. It was a really comprehensive presentation. Thank you. So this concludes our presentation for today. Thank you for listening. Dr. Nadir.
Thank you so much, Dr. Namar, and thank you all the presenters, Dr. Abdullah, Dr. Nadine, and Reem. And both topics are very important, and it's better to have good idea and grasp about the topics. I'd like just to share one personal experience with you guys. When I did my internship, that was in New Jersey, the first month we had a case and we presented that case. The case was an older lady who had back surgery. So it ended up she was using the bathroom and developed a DVD that went to her lungs, so PE basically. But she fell down and we couldn't open the door for that bathroom until we called the fire department and so on. So it was a case that happened after surgery. So it's an important topic and it can lead to fatal results. So it's very important to keep an eye on patients who had surgery, joint surgery, back surgery, joint replacement, and so on. Just pay attention to any symptoms. Try to continue with the DVD prophylaxis. As long as they can ambulate, that well and good. So we will encourage them to do that. We focus on pain control and we focus on rehab so they can be able to move and prevent the formation of these clots. But thank you so much. This is very important. Two topics, heart failure and DVD prophylaxis, especially in the setting of surgery or after surgery. So the other topics that we will talk to you about today, one of them will be how to use AI in medical research. But before I do that, I want to compare the available AI tools. So I'm going to share my screen with you guys. So we have a couple of options here. One of them is Google. It's Gemini, and now we have Gemini 1.5 or even 2. So you can upgrade using the free version. There are other options as far as prices and paid options. There is a ChatGPT, and there is another one, which is CoPilot. It's from Microsoft. So you can log in using your email and use prompt as you think might help you. The new tool that is in use is a DeepSeek. It's similar to ChatGPT, similar to Gemini and CoPilot. So any one of these 4 tools can be used. And sometimes one of them might be very robust and helpful in an area, while another one is not that helpful. So what you can do is you can try and use one, and if you don't get the results that you think is better or best for you, you can use the same prompt in another tool. Let's say, for example, we want to talk to you about just AI in medicine in general. So I'm gonna go to this DeepSeek, I'm gonna log in, and my prompt will be like, you are a professor who is teaching international medical graduate about AI. Please outline a presentation about this topic. And the AI will list all the outline steps. So an introduction, maybe 5 minutes about the topic. Then we'll go over the definition and the application in medicine and so forth. So it will create, let's say, 8 slides. If you want more, you can define how many slides you want. If you want deeper details, it can create that. If I want to talk about specifically AI in research or clinical research or medical research, then I can modify that prompt. To do that, you can just click on edit message and you can create the new prompt. So you can modify that to indicate what exactly you want to get from that outline. So here I ask about maybe increase the number of, I ask about the time limit. So I want only a shorter presentation, maybe 10, 15 or 20 minutes, because here it give me for each part how many minutes. So 5 minutes, 10 minutes, and then 20 minutes, and then 10 minutes mostly. Like if you add this and another 10 minutes for cases, 10 minutes. So more than 1 hour or 90 minutes in total. So I don't want to spend the whole day talking about AI here. So I wanted only just a brief talk, 15 minutes. So I modified my prompt. So here the shorter version. So the introduction, instead of 5 minutes, now it's 2 minutes. The definition, instead of 10 minutes, 3 minutes, and so on. So it's kind of a shorter version of the topic or the outline listed. So this is one way. And now I have the text or the outline. I want the AI to create the slides for me, the PowerPoint slides or the actual presentation instead of the outline. So I can prompt the AI. Now you can make the slides. So it's a deck of another 10 slides or 12 slides. So it will create the title for each slide, the subtitle, if any, and the content. And also it will suggest some imaging and or visual or graphics that can get along with the slide. So for each one, it will have the header, the content, and the visual possible image that I can add. And I can go over for the next slide and so on. So this is what they suggested for me. It's about 12 slides, 13 slides, maybe 14, 15 slides, along with the thank you slide at the end. So I got the text for my presentation. I wanted an extra help. So this time I want the AI tool to create the speaker notes. So here I modified or added another prompt. Now as a presenter, please add the speaker notes. Sometimes you can identify the level of speaker note that you want. So from the start, I told them I'm gonna present to medical graduate, international medical graduates. I can specify more if I want to talk in a public speaking, like for public people around there about a topic. So I can specify in a tone that 7th grade English, for example. So it's gonna be a little bit for laymen. You can specify if it's professional or if it's just casual talk. So you can add more details in the prompt here. So for now, let's say just a speaker note for the slides that it's made. So for each slide, it will create the text or the speaker note. So instead of for you to come up with any out of the blue, just you want to speak about the slides, the text, here it provides you with some text that you can just read as you go along for each slide. So this is another way of helping you create a presentation. And if you don't like it, you can regenerate that. So it will create a different text for you and so on. So I wanted to get all these slides in a table so that I can put it in an Excel sheet, for example. So I know the slide and the content for each, so I can move around if I want to, or I want to think about what's the sequence of these slides, the topic. If I put it in the PowerPoint slides, it's kind of lengthy, long file, but I want it in condensed or a short one table format. So I asked the tool, can you combine the above table format, including the following headers? Let's put the slide number, the title of the slides, the header of the slide, the content, so the bullet points, and the visual, if there is any suggested images, and the speaker note, if you look at that. So I can go and see how the flow of these slides, does it make sense to go in this sequence, or should I move, for example, the types up here, for example, or the key in medicine or something like that. So this is one way to get all the data for the presentation in one table, and you can review that faster for you. So you can download it as a CSV or comma separated values or an Excel sheet, and you can use it in Google Sheet, for example, or any other spreadsheet program. So this is one way of collecting all the data in one place. While I was doing that, it suggested some Figma, which is another tool. So I asked, I have no idea about Figma. Can you teach me something about it? So it showed me it's a powerful tool. It's a cloud-based and it's user kind of experience design. So basically, it's a tool that you can use to design. For example, if you want to develop an app or develop a web page or develop something that a user can interact with visually, then you can use Figma. It has two options, a screen where the user will interact with, and then a background where the program will do something. Let's say I want to calculate the ABI, the BMI, for example. So the user will have a page where it will ask about the height and the weight in, let's say, pounds, and the height in feet or inches. And then there is a button where the user can click on it, and then at the back end, it will take these two values, multiply using an equation, and then display on a different screen the result, or the same screen, but the result will appear on that screen. So this is basically the design tool for such thing. So you need to set up an account with Figma through the website and so on. So this is how the steps for me, if I want to use that tool to get something out of Figma. So far, I just want to know how to use this tool. You can do the same prompting using the Gemini, the same one here you can add, or CoPilot or ChatGPT. So back to the use of the tool. Today we talked about heart failure, for example. Dr. Abdullah did a great job presenting that topic. However, the slides that he used, it's from the AGS, which is the American Geriatric Society, and that was made up to the year 2019. Since 2019 to date, there are things that change over time. So I wanted to update the slides that Abdullah used. So maybe it's just a few sentences here or there, or maybe the definition, or maybe the classification. So I asked, can you teach me about heart failure, specifically about the types of heart failure or classification using the ejection fraction? And here, if you see, it went over the basics, like the heart failure definition, the same slides basically that Dr. Abdullah mentioned, the ejection fraction, which is basic normal numbers, and then the definition of preserved and the reduced. And then here, if you see, there is a mid area or range. Below 40 or 40 and below is reduced, 50 and above is preserved. What happened in the between the 41 to 49? This is another classification or another class that's emerged in the last 5 years in medicine. So cardiologists came together and they decide, hey, we want to divide the heart failure classification into reduced, preserved, and then there are a group of people who are in between. So we don't know what to do with this. So they came up with this classification. And the management, they said, maybe it will go along with the reduced group. So as far as the management, they wanted to use the same approach for the reduced group, if that makes sense. So this is just to update the presentation that was already in our app or available for you. So you can get a new information up to date. If you want, you can use the same. I'm gonna just give you a demo here. So if you go to Gemini and you add the same prompt, I want to teach about heart failure using this classification. So here it will divide them into using the F or the ejection fraction, and then we'll do the actual definition like classification, and it will add the third option, which is the mid-range option here. If I want to place this in a table, for example, include symptoms and treatment. So here you can see it will create a table format, and that table format can be exported as either Google Sheet, or you can download it later on as comma separated value files or Excel file. So if you see here, the type listed, the ejection fraction, and then the symptoms for each classification, and then what's the treatment option. And here you can export this as a sheet, Google Sheet, for example, and so on. So this is how you can use AI to help you update your presentation, or even with clinical research. Let's say I'm gonna here, I want you to write, let's say, an outline about the basics of clinical research for an international medical graduate who is interested in fellowship in geriatric medicine. The more you give specific information, the better the results will be. So here it will identify the topic for you and write the outline for you. So you need an introduction about clinical research, key concepts and terminology, the ethics, and then the conducting the research or the clinical research, the how to do the analysis, how to do the reporting and dissemination of information, publication, conference, oral presentation, and so forth. And here, special consideration for a specific area, like we talked about research in geriatric, for example. And here are some resources and the conclusion for you. So in a brief short time, you can get the outline, and you can do the same for if you want to present this, it can create the slides for you, and then you can get the speaker's note. So far, so good, but I don't want to spend some time copy paste this into a slide, a PowerPoint slide or Google slide. So there is a way to also automate this method. One way to do that is to ask it to create a code where you can use the code so that it can create you the slides in, for example, Google Slides, or a code where you can use it in PowerPoint. So you don't have to copy paste all this. I'm gonna go back here, and if, let's see. For example, here I have the slides already made. So how can I write this as a code for Google Script to create the Google slide presentation? So when I gave this prompt, it created the code for me, Google Script code with the content and the titles of the slides and the suggestion speaker note, for example. And it showed me how to integrate this, what the steps to use it in Google Slides. So I have to go to my Google Drive, create a new slide, go to extension, and in the extension, there is a script app. Usually there is a content in that script file. I will delete all this content because it's just like a space saver. And then you can add your code, which is this. So you copy this from here and add it to the file that has the code. And then you run and you give some permission. So I'm gonna show you, for example, something like that. Let's say you can copy this, the same, and then you put it in the Google slide. So why don't we do that? Let's say copy, and I'm creating a new slide. Let's say slide new. This will create a new slide that's empty. If you go to extension, go to apps script, and as I said, it will have 3 lines or 4 lines here. So this is just a space saver. You delete that, and then you paste the content of the code. You save this, and you can give it a name. Let's say script 1, heart failure update, for example, and you rename it. So this is the code. If you want to run the code, it will ask for permission. You give the permission and say yes, advance, and you go ahead. And it will ask allow. You just allow that code to go along. Sometimes you might get an error. Let's say this is an error that I got. So the code step stops in the middle. So I copy that I go back to the ChatGPT, I give, or in this case, DeepSeek, I give them the error that I got. So I got this error. So it will try to fix it and give me another code, an updated one. So I'm gonna get the updated one here. I go back to my app script, delete the old one because it has an error. I paste the new one. And now I'm gonna save it and run it again. So this is the new one. And if you see here, it will go along and execute the code completely, and it will show me where my new file or new slides. If I copy that and open that file, it will have the heart failure. The next slide is ejection fraction, the types, and so on for the. So it's kind of copy paste for you the whole data that created by the AI tool, in this case, DeepSeek. You can do the same with Gemini. You can do the same with CoPilot or ChatGPT. As I said, some of them have some tools that you pay for like a fee, $25, $20 a month, something like that, to get more features. But for our purposes, we can use the free version for each one of these, and you can get the results that you need. So it's kind of a tool that can help you prepare for a presentation or get a presentation and update the recent information about that. You can add it to the same presentation and so on. So this is what I want to update you as far as the tools for presentation, getting the content and creating the content, generating the content, and copy that content into either PowerPoint slide or let's say Google Slides, for example. If you want to, there are other options where you can generate the slides using a slide generator. You don't have to go all the steps that I just showed you. One option is called Gamma, for example. This is for example, it's a presentation tool that you can create a presentation for you. So you can sign up for free, you can log in and so on. But it has the option of adding the content and then creating the slides for you, like the background, the images, and you can modify the images. So you don't have to spend a lot of time. It's just a nice way of doing it. Again, it has a free version and it has a paid version. For the purpose of the presentation, you can use a free version for this tool. And there are other tools similar to this one. If you go back, you go down, you have beside Gamma, you can find PopEye. It's a different slide generator or PowerPoint slide generator. There are other Plus AI and so on. All these are tools to help you generate the content and generate beautiful slides without spending a lot of time. Some of them you can add, for example, CoPilot, you can add it to the Microsoft PowerPoint, and on the side you will use it as a tool to help you modify the content or the slide display or the theme and so on. So it's just another way of doing your presentation. in a short time instead of the whole spending a lot of time just preparing. And the good news is you can use it to create the speaker notes. So you don't have to struggle with what you're going to say about each slide. It's already written. So you just read them for the presentation, and hopefully this will help you, if that makes sense. Any questions or any comments or any addition? Thank you.
Thank you, Dr. Nadir, for this very informative presentation and discussion about the AI. It's truly impressive how the AI is helping medical professionals and physicians, and it makes lives easier. It saves time, and I think it has a lot of things yet to come. However, I have a question in my mind, and I believe most of us we have. Um, it's while it's impressive, it's scaring and concerning at the same time. What are the challenges or the risks the AI takes or carries with it? So I would like to hear from your perspectives. What do you think are the challenges that we might face as a physician when using AI in medicine, or in general? What would be the or could be the downsides of AI when it's used in medicine? Thank you.
Thank you so much. It's a great question. And this is a lot of people are working on this question because it's, as you said, it's a very useful tool, but it's a two-way, or it can harm as well. So the best option is to understand the concept of the AI itself. So it's data driven. So what you put in a lot of data to the machine, and then the machine will analyze that data and then come up with, let's say, a presentation or an answer to a question or some solution. So if you put in a lot of wrong data, then the output definitely will come wrong. So garbage in, garbage out, what they say. So for example, a few years ago, let's say 2 years ago, when ChatGPT came, it came also with a tool where you can identify things using an image. For example, I can use AI to identify you as either a male or female from your image, just displayed in this screen, for example. So to do that, I'm going to teach the machine to identify females. So I'm going to add a lot of images for females. And then each time I'll teach them, this is the female, this is the female. Or it will try to identify what the features of a female. And then on the other side, I will add a different set of images for males. And then the machine will learn, oh, these are males. And then it will recognize the difference between female and male. And if I give that machine another image of a new person, it will try to identify, is this a female or a male? So far, so good. The problem is when they used this method in the US, it was perfectly fine. But when we applied the same method in Africa, it did not recognize a lot of female like from males. So what happened is in the US, a lot of females, they use makeup, let's say they add lashes or add lips colors. So the machine will pick on different little things on the images that provided from the US, and it will recognize male, female because of the pattern. But in Africa, let's say, you go to rural area, maybe people are not using these makeups as frequent. So if you take a picture of a person there, it will be indefinite for the machine to learn, oh, what's the features? I was basing my feature on the makeup. So now a person doesn't have a makeup. Maybe person is a male, if that makes sense. So this is one draw. It's called a bias. So if the data in the US based on white American or Caucasian, a lot of the information goes to the data set. So the machine will learn about the white Caucasian patients. If I want to apply the same concept to the Black African American, it will get a little bit confused and may give me error or mistakes. The same way, if you look at it from the other side, so a lot of African American in the US, they have hypertension, heart failure, kidney disease, and they end up, let's say, with dialysis. So if you give only this data, then any information that will be asked later on, it will be answered from this data, and you will say, oh, you will be at high risk because only you have background of African American, if that makes sense. So this is one problem with AI, is the bias or the data in, data out. The other problem is privacy. So I would like to draw your attention. If you are going to use one of these tools, don't put your names or private information about you or about your patients. Let's say if you have a case that you want to understand more, don't put the whole case, just de-identify and put the case to the tool, and it will analyze and give you some data output. So privacy is a very big issue. As far as research, for example, the problem will be using AI to create content without the author. So I can write an abstract without me putting any effort. I just give a prompt to the AI and it will generate the whole thing for me. So I can write a paper, for example. So most of the journal nowadays, they have their own policy as far as how much you use AI tool in writing your paper. It's supposed to be your own words. It's not the AI words. And using different tools to recognize the AI input, you can get your paper rejected because it will compare that to what's in the data set in general. So let's say you write a paper using AI, submit it to a journal, they use another tool to identify if this is generated by AI or by human, and it will give a percentage. If it's, let's say, more than 25%, then automatically your paper will be rejected. And same with other, like if you submit, we have a topic where we submitted an abstract, a paper, and it compares the content with the content of a different paper, but because we use the same, let's say, template or format or questionnaire, the same questions appeared in another journal with same. So our paper was, let's say, 70% compared to the older published data. So we got rejected because of that. So we have to be very careful as far as how we write our own either abstracts or papers using our own words or English. It can help us modify or improve the English, the grammar, the content, but we don't use it as a whole. So Thank you.
Thank you, Dr. Nadir, for this great and thorough answer and for sharing your perspective with us. Yeah, that's really helpful. Thank you.
Thank you so much. Anyone wants to add anything or any updates as far as the projects, any ideas, any comments about the fellowship? Please go ahead. So I know some of you are working on some projects, and if you have questions, you can reach out to the seniors in your groups. If you have additional questions, please feel free to reach out for clarification or answers. I'll be happy to help as much. So you can contact me via email or text. Go ahead, Dr. Omar. Thank you.
Hello, Dr. Nadir. Thank you so much for the very informative information about using AI. I have a problem with access to the Web of Science. So is there any way anyone has an account or over the fellowship program can help us with accessing some websites like Web of Science or Scopus, for an example?
What problems do you get? Is it the paid version or what exactly?
Yes, the paid version, because I don't have an account in Web of Science.
Sure. Let me figure it out. We'll see how it goes. Did you use the big group of the WhatsApp? See if there's anyone of the fellows can
Yeah,
help.
I asked like 2 or 3 days ago, but I think no one answered. Maybe no one has an access. So for this time, I need access to Web of Science. Second thing, because in the future, if I need to get an access to a certain website, who should I contact? I should contact people in the group.
Yeah. So what happened is because we have graduates from this program, some in internal medicine, let's say, or family medicine, or even geriatric medicine fellowship, other fellowship, we can try to reach out to these graduates because they already now they are either working with universities or institutions or they have access, but they may not be able to spend time in the research work. So we can ask them to contribute by just giving us the access to using their institutions. I know, for example, Mafaz, she is in Florida. I can give you the contact information for her or other fellows. Lubaba in New York, upstate New York. So I know they can have some access, but I'm not sure if they can access the WebMD or the websites that you mentioned. So I will just give you the contact if you can reach out to them. In the app itself, if you go to the app, let's say here, there is a list of matched fellows. So For example, you can reach out to Serene. She's in New York, in Chicago, and this is her phone number, and you can reach out to Nabila, for example, this graduated last year. Maybe one of these fellows will be able to help you access some of the content. Rufaidah, she also one of the fellows, she was here with us. So if you can reach out to one of these, they can give you hopefully an access to some of the data that you need. Thank you.
Hello, Dr. Nadir.
Hello, Dr. Inas, go ahead.
I have a question regarding our project. I've sent you the protocol for the project. It's a systematic review in pediatrics. Our problem is that the project, when we started searching, we had like a lot of articles appeared around, I think, 7,900. So it's a big number. We tried reducing the number to around 2,000 by only putting only the last the papers from the last 5 years. The question that arose was what is the justification for it? Like is it like not enough that we're doing that in order to reduce the number of papers that we could screen? And also the topic at the same time, the topic it's about the effect of probiotics on malaria, on diarrhea in patients with severe acute malnutrition. The thing about it is that having it as a broad topic, it's going to give us like more results and more things that we can speak about when we're writing the article. But at the same time, it's going to make the searching for the articles really broad. So I'm not actually sure how we can minimize the number of articles and also getting to the point and answering like good questions instead of like repeating the questions that has already been answered in previous systematic review. So I'm not sure like how we can fix this problem. Thank you.
You're welcome. Thanks. So it's a good question. So to help you, I think you answered part of it is the question, what's the gap? What's the research question? So if you can find a good research question about the topic, then you may limit the number of the results that you get. And this will help you identify the keywords and some of the inclusion exclusion criteria will be depending on your question. To get a good question, as you mentioned, the topic might be already covered. So you want to get an updated version or a limited version for unlimited either population or location or time duration. So let's say you wanted the 5 years. So it's an update to the literature, what happened before 2019. Anything published at that time, it's before COVID. So maybe COVID might be an option to use as dividing area or keywords in your question. The other option is to look at geographical location. If you want to use it in Africa or in Asia or the cohort itself, maybe you want to do it in certain population, Middle East, for example, or the time period, as I mentioned, just the last 5 years. So using the keywords, using location, time period, sometimes you can limit only with English language as a publication. format, that might be a good option. This is what I think about when I'm advising, like you write, because any question can be broad, and you can get a lot of data, and it's not going to be as useful if it's already in the literature. So the more specific, the better option that you can get this published, because you are adding more data to the literature in a specific area, if that makes sense.
Yes. I just have a concern regarding the it being specific. So if I said, like, for example, if we're going to study only the duration of diarrhea, for example, or the hospital stay, the thing about it is that this part has been already answered in the in a previous systematic review. If I wanted to like use or if I wanted to have like another question, or if I wanted to make it broader, it's going to help me answer more questions, but at the same time, the articles are going to be more. So I
How do you
think
want
my answer,
to make it broader?
you
Can give me an example.
like if I said, what is the effect of probiotics on diarrhea and patients with systematic on patients with SAM, severe acute malnutrition? This is going to make it broader, but at the same time, it's going to answer like the question.
Did you try to limit that to an area, let's say in the Middle East, in North Africa, or in Asia, or in part of
No,
the US?
we did not do that. We did not do that. But
Yeah.
I think I'll use this. I'll use this. I'll use your advice regarding limiting the area. But at the same time, will it be something that the publishers or the journals will they be interested if we only limit it to Africa, for example?
Not necessarily they will be because it's focused on an area or a population or a duration, so they might be interested in that specific.
Mhm.
So when you target the journal, see what their interest.
Okay, I understand. Thank you so much.
You're welcome. Thanks. Any other questions or any other comments, suggestions regarding the research project? Any updates or the program itself, the fellowship? If not, then I'd like to thank you all for attending this Zoom meeting. Thank you, Dr. Namarak and your team. Thank you all the presenters from today. You did a great job, and I'd like to thank all those who will look at the recording later in advance. Thank you. Have a wonderful day, and see you next week. Assalamu alaikum.
Thank you, Dr. Nadir. Thank you so much.
Thank you.